Welcome to the assessment and management of the gynecological patient. Let's go ahead and get started. When we think about the gynecological patient and our assessment, we have to think about the most common complaints that we deal with. These are the primary complaints of abdominal pain and vaginal bleeding. These are most oftentimes due to issues with the reproductive organs. Um, when we complete our assessment, we're going to conduct ourselves in a very professional manner. We're going to complete our initial assessment, focus history, and physical exam as we would normally. We may pay closer attention to things like an abdominal assessment or as part of a physical assessment, or paying close attention to vital signs, as well as gathering a history in our OB patient or a gynecological patient. We want to make sure that we recognize that most patients are reluctant to have conversations about the reproductive or sexual activities. And so we want to try to keep that in mind of who's around us and how we're gathering and when we're gathering that information. If the patient's reluctant to talk to us about these issues, respect their wishes and transport them and treat any life-threatening injuries that would appear as if it was any other patient. Now, your history, we're going to focus again on our initial assessment, primary airway, breathing, circulation, disability, and exposure. We're also going to pay close attention to sample history. What specific symptoms do we see? Is there any discharge, abdominal pain? How does the patient present? Do they have any allergies? What type of medications have they had? How many pregnancies, births, or abortions have they had? And then are they having any additional pain? Pain on pain on intercourse or pain on discharge. We also want to know if the patient's ever been pregnant. We know that if there's a possibility that the patient's been pregnant, we want to take that seriously, especially if they're of childbearing years and complaining of abdominal pain. We want to document when was their last menstrual cycle, recognizing that normal 28-day cycle should occur. That doesn't always happen. So there's going to be times where we want to pay close attention to that. We also are going to want to go ahead and focus on medications. What type of contraceptives have they been taking? Have they been taking any, and are they compliant with them? There are a number of contraceptive methods, everything from the rhythm method to tubal ligation, diaphragm, spermicidal lube, the Nuva ring or vaginal rings, corpus interruptus. If you watch anything with the Big Bang Theory, you'll have an idea of some of those. So the idea behind this is the patient on some type of contraceptive method? Not necessarily just a medication, but a method in general. Our physical exam is going to focus primarily on the reproductive organs only if it's necessary to complete that assessment. We again want to remember to respect our patient's privacy, limit the personnel that are observing the patient, maybe those that are nearby, and then just kind of be very conscious of the patient's feelings of anxiety and dealing with this very private situation. Make sure that you're professional and explain all procedures. Observe your patient's presentation, how they're presenting, their nonverbal cues. Are they guarding? Do they have any signs of issues with level of consciousness, general appearance, color of skin, mucous membranes, key things to pay attention to. We also want to get some assessments of our vital signs. Vital signs can tell us a lot. It can tell us if we're dealing with signs of stress or anxiety by increasing heart rate or increasing respiratory rate. That could be along the lines of a fever with an increased respiratory rate and an increased heart rate. We also can see that for significant hemorrhage, if the patient's having a lot of bleeding, we may see hypotension and tachycardia as part of it. We also want to recognize that to identify if the patient is having any type of vaginal bleeding or discharge. First off, we never ever perform any type of vaginal exam in the field ever. But it may be potentially necessary for us to do a visualization of the patient's it may be necessary for us to do an external vaginal exam by doing only visualization. In this case, is there any excessive fluid or bleeding, or is there any type of crowning that might be present? As far as the abdominal examination goes, gently palpate, assess for any types of masses or distension, pain on palpation, rigidity or tenderness, and then listen for bowel sounds, hyper or hypoactive bowel sounds as well. When we deal with the management of gynecological emergencies, there's a number of things that we have to focus on. First is we're going to focus on supportive care. Most of the things that we're going to do are going to be supportive in nature, keeping mom's comfort level where it needs to be, providing emotional support. It may be necessary to provide oxygen by nasal cannula according to your pulse oximetry, or even assist ventilations in a very sick gynecological patient. If we recognize shock, we should treat it immediately. And these include things like IV access, cardiac monitoring, and we really don't do anything with the new anti-shock garments anymore. But we will need to consider some type of hemorrhage control. Now, if the hemorrhage is from vaginal bleeding, we're not going to go ahead and pack any type of wound. We're going to stack dressings on the outside of the vaginal opening and continue to stack, not pack the vaginal canal. Now, there are a number of specific gynecological emergencies that we're going to deal with. The majority of these are going to focus primarily around abdominal pain. These include things like PID or pelvic inflammatory disease, ruptured ovarian cyst, cystitis, Mittelschmerz, endometriosis, and ectopic pregnancies. Let's take a look at each one of those. When we think about pelvic inflammatory disease, this is where the patient has had an infection of the female reproductive organs. This can either be caused by bacterial, viral, or fungal. The most common causes of PID are things like sexually transmitted diseases, STIs, sexually transmitted infections, including things like gonorrhea, chlamydia, things of that nature. Now, PID is one of those things that have some predisposing factors that are associated with them. Some of those factors include multiple sexual partners, a previous history of some type of pelvic inflammatory infection, recent gynecological procedures, or they have some type of implanted uterine device like a Nuva ring or some type of PID. Signs and symptoms we typically will see with this are going to be associated with abdominal pain, and a lot of times because of these factors that exist, we know that if any type of PID begins, we oftentimes can result in infertility, where they'll have scarring of the fallopian tubes we talked about in our previous lesson. Most of the signs and symptoms, like we said, are going to focus on abdominal pain. Now, these may intensify either before or after the menstrual period, but typically you're going to see it's going to worsen during things like intercourse. We call that dysmenorrhea, where the pain is with intercourse itself or vaginal penetration. Now, patients may also walk with a shuffling type gait, and they also are going to have a yellow or foul odor smelling discharge from the vagina. They also may have spotting or a mid-cycle like bleeding that can happen. Now, your physical assessment is going to focus on the presentation of the patient. Does the patient look sick or not? If the patient looks sick, we're going to assume that they're most likely going to be toxic in some fashion or another. We also want to recognize, do they have pain on palpation or rebound tenderness that may be present associated with an appendicitis? Oftentimes that can be obscure our thoughts if it's actually truly a PID. We also want to recognize, does the patient have a fever? A fever is going to be an underlying clue that there's some type of infection within the body and can point us in that direction. Treatment, definitive-wise, is antibiotics, especially if we're dealing with bacterial infections. Pre-hospital treatment is generally supportive. We want to have gentle handling, allow for slow movement because of the significant amount of pain that can be caused by PID. And then position of comfort, right? Knees drawn up or left lateral recumbent. However they're going to be comfortable, that's how we're going to transport these guys to the hospital. Could also go ahead and consider IV therapy in case we need to give any type of fluids, and cardiac monitoring as well. Oxygen based on pulse oximetry. A ruptured ovarian cyst is where we're dealing with a cyst or a fluid-filled pocket that's actually going to be on the ovary. Normally you're going to see this is where the corpus luteum cyst is often going to be left in its place, and normally it's going to secrete estrogen and progesterone until the egg is fertilized, but because of this, the cyst will collect fluid, and then we get an irritation of the perineum, which is going to result in significant amounts of pain. Now, this pain can be moderate to severe, but it's generally going to be unilateral, only on one side. And again, it can radiate to the back. Dysmenorrhea, irregular bleeding, or delayed menstrual period are all very common associated with the cyst. And these cysts may actually rupture, especially during sexual activity or physical activity, which can lead to vaginal bleeding or discharge. So the things to kind of keep in mind with a ruptured ovarian cyst: unilateral pain, one-sided, usually with some type of activity where the pain will be present, followed by some type of vaginal bleeding as well, or discharge. Cystitis is another one. Cystitis is a urinary bladder infection, usually involving is bacteria, and we know that it can progress all the way up to the kidneys and cause nephritis. Most of the signs and symptoms you're dealing with cystitis are a bladder infection, abdominal pain, increase in urinary frequency or pain or burning sensations with urine, And then low-grade fever is also very common. Mittelschmerz is another one. It's a German name for mid-cycle abdominal pain or middle pain. The peritoneal irritation that happens, it's associated with Mittelschmerz, is associated during with the follicle rupture. The follicle normally releases the egg at this time, and the pain that's associated with Mittelschmerz is typically self-limited. Signs and symptoms include things of a lower quadrant abdominal pain, potentially a low-grade fever, and the treatment is mostly based on symptoms. Endometriosis is now we're dealing with an infection of the uterine lining. This can happen for a number of reasons, including miscarriage, childbirth, or maybe they had a gynecological procedure like a D&C. What ends up happening here is we have inflammation, and the infection of the endometrium lining is now inside the uterus, and is going to cause a significant amount of discomfort. Now, with endometriosis, we're dealing with this mid to severe lower abdominal pain. We're going to have a bloody, foul-smelling discharge, typically a significant fever for an adult of 101 to 104 degrees Fahrenheit, and then typically we're going to see the onset of symptoms within 24 to 48 hours post-procedure. So something in the procedure went awry. There was tissue left behind. There was some type of infectious agent that was introduced, something along those lines there. Complications of endometriosis may include things like sterility, or they won't be left children anymore, sepsis in severe cases, or even death. Endometriosis, now we're talking a little bit different. This is endometriosis is the condition of where the endometrial tissue is found outside the uterus. We talked about this a little bit earlier in a previous video. It's most common in the abdominal and pelvic cavities, and the tissue still responds the same as any other tissue of the uterus in regards to changes in the hormonal cycle or menstrual cycle. It's going to bleed regardless of where its location is, either in the pelvis or in the abdominal cavity. Usually it's seen in the ages of women between ages 30 to 40. I've seen it a little bit later. I've seen it a little bit earlier as well. Most of the signs and symptoms of this are dull, cramping-like pelvic pain, dyspnea, abdominal uterine bleeding, and painful bowel movements as well. Ectopic pregnancy. With ectopic pregnancies, this is something that's truly a life-threatening emergency. It's one of the most common problems associated with the fallopian tubes. And typically you see that secondary to some type of endometriosis or PID or some type of scar tissue that's developed through those fallopian tubes. Symptoms for this, folks: severe unilateral pain with referred shoulder pain on the same side, shock, and late or missed period. Shock is a big one because if this were to rupture, they're going to bleed massively to the point where they may actually hemorrhage out. Most of your time when you're dealing with abdominal pain in a gynecological patient, you're really going to follow some basic steps. Give them oxygen, make them comfortable, put them on the monitor if necessary, and again, gain IV access as a lifeline. Make the patient as comfortable as you possibly can, and then transport them. That's probably the most common ones that you would see. Now, for non-traumatic vaginal bleeding, this is rarely seen in the field unless it's pretty darn severe. We can have extensive amounts of hemorrhage, which is called menorrhagia, which is referring to massive amounts of bleeding, excessive bleeding from menstrual flow, which is a little bit different than just typical shock because it's just heavy, excessive amounts of bleeding from the menstrual cycle. We can also see a miscarriage or a spontaneous abortion, another very common cause of vaginal discharge and bleeding, and it's normally going to be associated with cramping or abdominal pain, passage of clots or tissue as well. Other things you can see could be cancer, it could be pelvic inflammatory disorder, or even the onset of labor in the example of mucus plug or bloody show. Now, we're dealing with non-traumatic management. It's going to depend on the severity of the situation, right? Same thing, IVO2 monitor. Go ahead, and if there's any bleeding, stack those sanitary pads, keep track of them, and then transport anything that's discharged, clots or tissue, blood with you to the hospital so that it can be examined upon arrival. Now, there are some traumatic issues as well, too, right? Blunt trauma, sexual assault, blunt force, lower abdominal trauma, foreign bodies that can be inserted into the vagina, or even some type of abortion attempt. Let's take a look at those. Most of these management of gynecological trauma, we're going to apply direct pressure if there's any type of laceration. We want to try to stop the bleeding. Sources of bleeding may not be readily apparent, so we want to take a look as best we can. This is one time where we may need to do an external examination. We're going to apply a cold pack to any type of hematomas or swelling, get an IV, again, treat for shock if necessary, And then watch for potential organ rupture, because this can lead to things like peritonitis or diffuse abdominal pain. And then transport them appropriately. It's always a possibility that you may run on a sexual assault. It's one of the most violent, growing crimes in America. 60% of all sexual assaults are never reported. Male victims represent about 5% of reported sexual assaults, so there's not one specific type of victim that you would see, right? But we do know that most victims know their assailant. And it is a crime, right? Sexual assault is a crime of violence, and it needs to be treated like such. Your assessment for sexual assault: the patient needs emergency medical care and psychological support. We can't forget both. We got our primary care and our psychological support that's necessary. This is a crime, so we need to make sure that we're paying attention to those legal considerations. We're not going to question them about what necessarily happened in the field. That's not our place. Our place is to treat the patient's injuries and provide psychological support, making sure we respect the patient's modesty as well. We do need to protect the scene. We need to make sure that if we're touching any clothing, that we're handling it as little bit as possible. If we're going to take the clothing with us, we're going to put them into a paper bag. Paper bag allows for moisture to escape. It's going to allow for the DNA to remain intact so they can do testing. Again, we want to make sure that we don't cut any holes. We don't do any type of cleaning or anything of that nature. We really just want to focus primarily on getting them to the hospital, placing their belongings into a paper bag so that way it can be examined later on. Again, we're not going to examine the peritoneal area. Do not allow the patient to actually change their clothes, to bathe, or to douche. Do not allow the patient to comb their hair, brush their teeth, clean their fingernails, shower, anything along those nature to clean wounds if all possible. Because if we do, there's a likelihood that we may destroy any of that DNA evidence that's there. And so again, we want to keep that in the back of our minds, help protect their case. Last part we look at is documentation, right? Documentation is really is important. That's because we know that regardless of the case, there's legal considerations and ramifications that can come from sexual assault or even just from general gynecological emergencies. So anything that the patient states, we want to make sure is accurately documented in our patient care report. We want to objectively state what we observe, right? The patient's physical conditions, the environment, any torn clothing, document evidence that you turned over to the hospital staff, and then don't include your opinion, whether you believe rape had occurred or not, or again, just the facts is what we're shooting for. So in this lesson, we talked about the anatomy and physiology of the female reproductive organs. We talked about the menstrual cycle, the assessment and management of the gynecological emergencies in patient, and then specifics for each individual emergency. So I hope this was helpful. Continue to use the resources in your online lessons and get a hold of me if you have any questions. Thanks, and we'll see you on the next one.